is a neonatologist and pediatric intensivist at the Children's Hospital, University of Bonn in Germany. He is an associate professor of pediatrics and the head of the local CDH group, and he is an avid CDH enthusiast, and his research focuses on the hemodynamic assessment of CDH, as well as term and preterm infants without CDH. Dr. Kipfmueller finished his residency at Wuppertal in Germany before completing his fellowship at Bonn. He also did a research fellowship in radiology from Harvard Medical School. We're going to be discussing today a very interesting topic on the hemodynamic management options in the CDH population, and we're really thrilled to welcome you, Dr. Kipfmueller. Following his presentation, we'll have a discussion with the panelists, and I'm very thrilled to welcome our esteemed group of panelists today. We have Dr. Neil Patel, who is a consultant neonatologist at the Royal Hospital for Children, Glasgow, a senior NHS Research Scotland Fellow, Scottish Quality and Safety Fellow, and Clinical Innovation Lead for the West of Scotland Innovation Hub. His clinical and research interests include the neonatal hemodynamic assessment and management, including the patients with congenital diaphragmatic hernia. He leads the local and international collaborations, including those within the CDH Euro Consortium and the International CDH Study Group. Thank you so much for joining us, Dr. Patel. Joining us also is Dr. Catherine Avitabile. She is an attending cardiologist, echocardiographer, and pulmonary hypertension specialist at CHOP, and assistant professor of pediatrics at the University of Pennsylvania Perelman School of Medicine. She's dedicated to improving the functional status and quality of life of patients with pulmonary hypertension, and has performed several observational studies and trials to improve the outcomes in this patient population. Welcome, Dr. Avitabile. And also joining us is Dr. Jason Gien. He is an associate professor of pediatrics and neonatology at the University of Colorado Children's Hospital. He did his medical school in South Africa, residency at CHOP, and fellowship in Colorado, where he stayed on as faculty. He has a basic sciences laboratory that focuses on the contribution of altered lung development in the development of pulmonary hypertension, and his clinical interests include CDH and ECMO, with emphasis on the cardiopulmonary transition from intrauterine to extrauterine life. I would like to extend our warm welcome to our panelists and look forward to their insights on today's topic. Thank you all for joining us, and I would now like to invite our speaker for the day. Dr. Kipfmueller, the floor is yours.
Thank you, Rupa, for the nice introduction and for being here leading this session. So let me start my talk. Great to see so many familiar names in the audience, and my talk today will be about the hemodynamic treatment options in CDH. I have a couple of disclosures. I received lecture fees from Gettinger, who is a company that produces ventilators, among others, and an unrestricted research grant from AOP, Orphan Pharma, which is the company that produces the drug Landiolol, which I will be talking later on. And also I'm a medical advisor for Xenios, who is a ECMO company. So very brief, I'm pretty sure you're all familiar with CDH. We have, it is a rare disease with an occurrence of approximately 1 in 4,000 neonates. The mortality remains at 20 to 30%, and 90% of the cases are left-sided, 10% approximately on the right side. For Germany, we have about 90% prenatal diagnosis, and ECMO utilization varies between centers. It's approximately 25 to 30%, but the 95% confidence interval that I put there is a little bit ironic, but it shows that there is a strong variation among the community. Nowadays, as I said, 90% are detected prenatally, and usually by the routine ultrasound during 20 weeks, sometimes a little earlier, sometimes later. And we get the observed to expected lung head ratio by measuring the size of the contralateral lung intrauterine. Additionally, we can do an MRI, and many centers are doing this. The measurements are a bit different. It is usually explained as observed to expected total fetal lung volume, We do both at our university in Bonn, but we rely more traditionally on the ultrasound. This is a recent article that we published from data from the CDH study group, and it demonstrates the survival rate and the ECMO utilization rate in accordance to the severity of CDH, described as the observed to expected lung head ratio. You see an increase by a decreasing severity, demonstrated by an increased percentage of the lung size. The mortality, as I said, is about 20 to 30%. This is also data from the CDH study group from Viktor Gupta, and he was able to show that during the last 25 years, the mortality decreased a little bit, not much, but it was possible to observe an effect. But as you can see in this registry, the mortality remains over 25%. So there is much space for improvement. So CDH, what's it all about? There are some nice pictures of Satyan Lakshmin Rushima. He's really fantastic with his graphics and his talks. So I'm very happy that I can use some of his figures. On the left side, you can see the pathophysiological background of CDH. Here on the very left, you can see a normal lung with a normal lung development. And in CDH, we have something called the dual hit hypothesis that was first described by Richard Kaiser back in Rotterdam. And he was able to demonstrate in an animal model that we have an early defect of the diaphragm, that the diaphragm is not closing properly in the CDH pups, and that the lung development is already abnormal at the time before the diaphragm closes, normally also in the healthy animals. And we have a second hit that is produced by the herniation of the abdominal contact into the thorax. So this is the dual hit hypothesis. Postnatally, these kids demonstrate with severe hypoxemia, among other problems. This is called the trifecta of CDH, and this is a description of the different pathophysiologies in CDH. It's, in general, it is accepted that these three factors are the major determiners of poor outcome and mortality. We have lung hypoplasia, which was recognized many decades ago, then pulmonary hypertension, which is also a phenomenon that goes along with abnormal lung development, and cardiac dysfunction, which has been intensively investigated within the last 10 years. So to go briefly through these pathophysiological components, lung hypoplasia, as I said, is this can be observed as a reduced alveolar count and a decreased lung size. You can see here in these radiographs two different kinds of CDH, a good one and a bad one, to put it simple. And these kids present clinically with a certain amount of oxygenation failure and hypercapnia. So the next pathophysiological phenomenon is pulmonary hypertension, and what we can observe is a medial hypertrophy in the small pulmonary arteries, and a decreased vessel diameter, an impaired angiogenesis and vasculogenesis, and an impaired vasoreactivity. Also, what can be observed, there are some studies that you have an increased inflammation in these kids, and probably also around the vessels. For the detection, we usually use echo, and I have briefly put in some echo slides here. You can see a tricuspid insufficiency here at the top, and then a ductal with two different kinds of ductal flow. And here on the lower part, there is a tissue Doppler of the right lateral myocardium. The next part of the trifecta is cardiac dysfunction, and we have several features here of cardiac dysfunction. The severe CDH cases, they present with a small left ventricle with either a good or a poor function, usually with a reduced cardiac output. We have a septal displacement, an enlarged right ventricle due to an increased pressure or high pressure in the pulmonary arteries, and this enlarges the pressure that compresses the left ventricle. We also have an impaired diastole and a reduced preload. In the lower part, you can see a normal sized left ventricle and with a more or less normal function in a CDH kit. So these are it's a kind of a spectrum. I know that there are many other different pictures how the heart can look during postnatal adaptation, but I think this is quite good to demonstrate the range. So I put this figure quickly together to describe that all these parts are interacted. They cannot see separately. Lung hypoplasia is very much related to pulmonary hypertension, cardiac dysfunction as well. So that should be clear to everybody. For the prenatal situation, we have already in utero an abnormal pulmonary vascular development as demonstrated here by this picture. And additionally, what we can observe also prenatally from the heart is a small left ventricle. This is present already early during 24 to 26 weeks of gestation, and we can also see this during late gestation. So we'll describe briefly what might be the reasons for the disrupted transition in CDH. I have this figure here from a recent publication. We see here a normal fetal circulation where the blood is coming through the ductus venosus and streaming into the right atrium and through the foramen ovale toward the left ventricle, and presumably shaping the left ventricle, giving its size. And what we see in CDH is that this ductal venosus streaming is disrupted and is redirected toward the right ventricle. So this might be a reason for the small left ventricle that we can see in CDH. And as you know from other disease, from hypoplastic left heart, which can occur after severe aortic stenosis, flow is very important for the ventricles to shape. And on the right side, we have the postnatal picture. What we can observe, we have the small left ventricle, which is also compressed by the herniated organs. And we have the right ventricle, who is dilated due to the increased pulmonary vascular resistance. And we have this shift of the right of the IV septum towards the left side. To go quickly through all these pathological abnormalities that we see, as I said, we have an increased pulmonary vascular resistance due to the intrauterine abnormalities that are part of the features of this disease. And this leads to right ventricular dilation after birth and right ventricular hypertrophy, also diastolic dysfunction. Additionally, we can observe early on a right to left shunting via the atrium or the patent duct. When you recall the echo that I demonstrated, you can already appreciate the poor function of the right ventricle, also the poor function of the left ventricle. And what can be seen on this echo is the ventricular interdependency. This has also been demonstrated in some very nice studies by Dr. Patel. And we can see that the dysfunction of the right ventricle also affects the left ventricle. It's not the only cause. It's not only the right ventricle that compresses the left ventricle. We have this prenatally pre-existent left ventricular hypoplasia. And also we have an increased afterload at birth, which make it much more difficult for the left heart to generate an appropriate cardiac output. We have a reduced pulmonary blood flow due to poor performance. We additionally have a post-capillary increase in the pulmonary hypertension due to the poor left ventricular function. The poor left ventricular function leads to reduced systemic blood flow. All these problems lead to hypoxemia, to respiratory and metabolic acidosis, to systemic hypotension, which additionally has an influence on some features such as the pulmonary vascular resistance and the left ventricular dysfunction. The fact that cardiac dysfunction is very critical in the course of CDH infants has been demonstrated by a study that we conducted out of the CDH registry. And as you can see here in the Kaplan-Meier curve, the kids with biventricular dysfunction had a much higher mortality than those with a normal function or those with an isolated right ventricular dysfunction. And there were also some kids, not much, 5%, who had an isolated left ventricular dysfunction. From my experience, we see those rather rare or rather seldom during early postnatal transition. In our hospital, it's rather a problem that we encounter in the period post-surgical repair. So to come back to these three phenotypes, it is a question whether we need a phenotype-based approach. This talk is about hemodynamic management. What can we do? And we always have to ask which is the leading problem in the individual patient. And we have to take the time when we see the patient early on to investigate these three features, to look for signs of lung hypoplasia, cardiac dysfunction, and pulmonary hypertension. And this is very important to come up with the right strategy. So for pulmonary hypertension, as we said, we have the increased pulmonary vascular resistance. We have also pulmonary blood flow that is a critical point for pulmonary hypertension. We have, as we said, the post-capillary pH, which can be caused by left ventricular dysfunction. We have acidosis, which is a very potent driver of pulmonary vascular resistance. Also inflammation early on, inflammation as a part of the disease itself, but also inflammation caused by sepsis, which can occur at any time during the ICU stay. And we have oxygenation and the PaO2 as an important factor. For lung hypoplasia, we observe low tidal volumes that we have to improve. Of course, there is a limit what we can generate. We can encounter atelectasis, so lung aeration is very important. It's very important to come up with a good pulmonary blood flow with a drop in the pulmonary vascular resistance. We have also overdistension. I will talk about this briefly a little later. And oxygenation and hypercapnia are also features that are associated with lung hypoplasia. For cardiac dysfunction, we can encounter poor contractility. I think this is very important to support the heart, that it can do the job it has to do. We have the small LV, which is much harder to treat or to go on therapeutically. We have the large RV caused mainly by the high pulmonary vascular resistance, septal displacement, preload, afterload shunts, and so on. So I want to present you a case. The situation is we are in the delivery room at birth. We have a male neonate, CDH 37 plus 2 weeks. A C-section was not planned, but everything went quite smoothly. Left CDH liver up, observed to expected lung head ratio 24%. didn't have a veto because it was in the total trial and randomized to the expectant management group. We immediately intubated the kid, and the ventilator settings were a peak inspiratory pressure of 25 and a peak of 4 with a frequency of 60 breaths per minute. We were able to install the central line early on. And after 1 hour, when we went to the NICU, we had a pre-ductal oxygenation saturation of 85% and a post-oxy of 72%. So that matches European guidelines and might be something to be satisfied with. We have a pH of 702 with a CO2 of 87 and a base deficit of 13. The blood pressure is not very high, 34. The tidal volume, 3.5 mL per kilo, is quite good. So the question is, are you happy? And what do we want to do? Am I happy? Sorry, I want to go back. Am I happy? In some extent, yes. So that is, I'm happy about the tidal volume of the kit, which is quite good, which might be promising. But of course, I'm not really happy with the oxygenation and pH and so on. So what should we do? Do we want to do an echo? Yes, of course. Although the more you deal with CDH, you know how the echo looks. It is this echo that I have to present. I have to make a little remark here. I wasn't able to extract many echoes from our system because our hospital moved the storage system of the echocardiograms to a different system, and now it is not able to download all the images. So I have some images later that I had to phone with my iPhone, and I apologize about this, but I did the best I could. So we can see this, and as we said, enlarged right ventricle, small left ventricle. What do we want to do? We see the tricuspid insufficiency. It is a suprasystemic pressure. It is the tricuspid insufficiency is approximately present, I would say, in 60 to 70% of these kids early on. Then we have a look on the ductal shunt, and we can see a bidirectional shunt, although the right to left proportion is quite significant. And we have many treatment options, and when I think about the medication that we can give, it always reminds me of this great Indiana Jones movie where they were looking for the Holy Grail, and they are in this room, for those who don't know the movie, and they have to choose among all these cups, which one is the Holy Grail, and this old knight, who is apparently 500 years old, tells Indiana Jones and the other guys, you must choose, but choose wisely. So they think about what might be the right medication to give. And for us to briefly come up, what can we do? We want to lower the pulmonary vascular resistance. We want to increase the pulmonary blood flow to a certain extent, not too much. We want to improve left ventricular function to reduce post-capillary pH. We want to come up with a good lung aeration, and we want to correct acidosis, maybe. So it would be nice if the acidosis goes away, but the question is, do we want to use bicarbonate to buffer it or not? For the cardiac dysfunction, our main aims are to improve the myocardial function, also to reduce the pulmonary vascular resistance, to treat tachycardia, and to aim for an optimal blood flow. I was putting optimal marked it because the optimal blood pressure is different for each CDH, or there are some margin, and it's not very easy to answer. I want to tell you what we do from our observation, that many of these kids are really doing bad. To account for lung hypoplasia, we do gentle ventilation. We allow permissive hypercapnia. if this is possible, I have the feeling that especially during early postnatal transition, it's not always good to have a high CO2. We use conventional ventilation, and we try to avoid lung injury as good as possible. For pulmonary hypertension, we start early on, already in the delivery room with prophylactic INO. We are very much aware of this, of the current evidence. It is a bad habit, maybe a good habit is a habit that we never got rid of. There are some molecular effects of INO that might protect. In this case, we also start early on with intravenous sildenafil, and we use generally a low PEEP strategy. For arterial hypotension, we start already in the delivery room when we put in the central line with very low dose vasopressin and norepinephrine, sometimes even lower than the dose that I come up with here. And it is that we have it running if the patient needs it. We see with our treatment that we encounter arterial hypotension. So we don't want to start treating when we are at a situation where we have profound hypotension, but rather we want to have it early on. Additionally, we start with milrinone 0.3 to 0.5 mic and dobutamine. So this is a mix that we over the years started early on or earlier on before the first echo. We do the first echo when we come to the NICU at about 1 to 3 hours. And then we see pictures like this. In a kid like this, we have the blood pressure of 34. I would like to have a little higher blood pressure. The PDA size is 3.7. Of course, it's always the discussion. Do we need to put the duct open, especially in a right ventricle like this? It might be good to have a blow-off valve. 3.7 millimeters are not bad. And what we do is we increase norepi or vasopressin. We have epinephrine, but we rarely give this. We might use additional hydrocortisone if the cortisol levels are low, so we can determine this in our lab 24/7. We have treprostinil, which I personally don't have much experience with, but it is very potent. It's of course not to treat arterial hypotension, but PPHN. And for the pulmonary hypertension, we start with INO and sildenafil, bosentan. We give a little later, maybe if they are on ECMO or in the post-repair situation. Prostaglandin E1, we also give rarely, and I explain a little later why. For cardiac dysfunction, we start with dobutamine, usually 5 mic, and add milrinone. Also, we have lots of experience with levosimendan, which I find very potent in treating cardiac dysfunction. And as you can imagine, with a cocktail like this, you are prone to induce tachycardia, which can be bad for the patient. And for this case, we use landiolol. We are all aware of the impact of pulmonary hypertension, so I can go over this. You probably are also aware that there are different pathways, the NO, guanylate cyclase pathway, the prostacyclin pathway, and the endothelin pathway, which we can use. For nitric oxide, it is important to mention that the studies that has been published, the major study was the Rios trial published in '97. They all show some or a bad effect on the outcome. So there is no study that really demonstrated the benefit, at least no appropriate, well-designed randomized controlled trial. We have to keep this in mind. The design of the Rios trial is not optimal, so the randomization happened at a very late stage when the oxygenation index was already very high, and then at the point where the kids received INO, it was already at the level where we would install ECMO nowadays, at least in our center. There is another study. It's not only the Ninos trial, it's also this study is from the CDH registry, very sophisticated statistical method, and they were able to demonstrate also a negative effect of INO on the mortality. This is registry data, so we have to be careful about this, but I think it is important to mention this for discussion. And then we have this work here from the group from CHOP, who observed a respondence rate in about 30% of the patients receiving INO. They were able to demonstrate that the response to INO therapy was associated with a lesser degree of left ventricular dysfunction. And this is something that is important in the entire discussion. If you decrease the pulmonary vascular resistance and increase the pulmonary venous return, you have to be sure that the left ventricle is able to do its job. And if it's small and poor functioning, you might end up harming the left ventricle. That's the reason why we start with prophylactic milrinone. We have some other circumstances or other disease, especially in cardiac surgery, where we start with prophylactic milrinone. So personally, I think it's a good idea. We have a certain proportion of kids where we have the feeling that the patient might benefit from it, and in those who might not need it, usually it will not harm the patient. And there is an endless discussion about the last sentence, and I'm happy for the panel discussion and your questions on this. So for sildenafil, this is some data from our institution from a couple of years ago. We were able to see that about 42% of the kids responded with an improvement in oxygenation, and also with an overall increase or improvement in pH severity, but we were able to see a high failure rate in those kids with left ventricular cardiac dysfunction. The reason for us to treat these kids, mainly all of them, with sildenafil is that sildenafil has also the ability to protect the lung from hyperoxia-induced lung injury, and as the recommendation goes, to start with high oxygen, 100% in these kids during the delivery room management, we are prone to hypoxia-induced lung injury. That's why we have this as a medication early on, and the hypotension that we see is usually manageable. So milrinone, this is a study also from Dr. Patel already 10 years ago from his experience in Melbourne, where he was able to see an improved oxygenation index with the use of milrinone. He was also able to show improvement in the ventricular function over time. And I think this is common sense nowadays, and the rate of hospitals who treat patients with milrinone is very high. So the second medication that we use for cardiac dysfunction at our institution is levosimendan, also something that has been used by pediatric cardiologists for a long time to prevent low cardiac output syndrome. And it is a calcium sensitizer. Also, it is a PDE3 inhibitor, and we were able to demonstrate in a small study of 24 kids that we could treat these kids and improve the right ventricular and the left ventricular dysfunction when measured after 24 hours and 7 days. Additionally, within the first 24 hours, we saw an improvement in the oxygenation with a reduced FiO2 with a stable blood pressure, although the vasopressor score was increasing during the treatment. To give you some data on the tachycardia, This might be a problem mainly of our institution, but many of you might experience also cases or kids with tachycardia. So tachycardia can reduce the diastole, and it can lead to an increased myocardial oxygen consumption and also an increased pulmonary blood flow, which can enhance pulmonary hypertension. So under some circumstances, it might be good to reduce and control the heart rate to bring it to a lower level. Let's say we aim for 150 beats per minute, of course, with close echo monitoring, and with landiolol, which is highly selective beta-1 blocker, we are able to achieve this goal within 60 minutes approximately. So briefly on the prostaglandin E1, we don't use it that much, but we have with the levosimendan and the with the Mirinone 2 medications who have an effect on the ductus arteriosus. For those of you who are interested in prostaglandin, I can recommend this fantastic review recently published in the Frontiers of Pediatrics by Dr. Gopal, and to show you some data that Mirinone might have an effect on the patent DA. Here's some animal data. When they give Mirinone to these kids, they have a longer patency of the duct, and this is also something that we see. So with the medication that we use, we don't need to use much of the PGE1. Treprostinil, this is probably something for the discussion, and Dr. Avitabile from CHOP might talk about this because they use treprostinil much more often than we do it. I think it's a good to talk about this. Very briefly, because I know I have to come to an end with my talk. We have the cardiopulmonary interaction, and there is a dependency of the pulmonary blood flow and the pulmonary vascular resistance caused by the lung volume that we apply. So ventilation is not only good for bringing oxygen to the lung, but also the pressures can lead to an opening of the lung, of course, and an overdistension. It is not sure what the optimal PEEP is in these kids. I was saying earlier that we use a lower PEEP, around 2. We do also some studies on electrical impedance tomography. Dr. Schröder from our department is very intensively investigating this to define an optimal PEEP in these kids. And it looks like that the PEEP before repair is the optimal PEEP might be 2 or something, and afterwards around 4 to 5. But this is preliminary data and open for discussion. One study who was investigating this is the one from the group from Laurent Storm from Lille in France, and they were able to see post-repair when they ventilated kids with a PEEP of 2 versus a PEEP of 5, that were much easier to get rid of the CO2 with a lower PEEP. So these are some pictures of the EIT studies that we do, more in a future talk. Then again, what I was mentioning early on was the question whether permissive hypercapnia is always a good idea. We love permissive hypercapnia because we all understand that ventilation can be really a problem for the kid. And I have this figure here from the Fuhrman textbook, where you have the dependency of the pH and pulmonary vascular resistance. So it might be good to avoid and treat acidosis. So here's a picture when things go wrong. When we take the wrong GRAIL, he chose poorly. We have a very much dilated left ventricle due to high dose presses and no inotropes. And with the right management, dobutamine, Mirinone, levosimendan, we were able to improve the function. And also we used Avitabile which is an alpha blocker, which we use to reduce the afterload. So it was a wise idea in this case because the patient improved very much. And with this, I come to the end, and there remains some question. Is there a role for prophylactic treatment? Maybe you all think I'm ludicrous, or we are here ludicrous to come up with something like this. But we didn't want to come always to the situation where we start treatment at the point where it's pretty late and the patient goes already to ECMO. The other question is, like with sepsis, is hit hard and early an option? It's pretty much in the same direction. I would say hit smart and early is a good way to go. And with this, I want to thank all of you, especially also from the panel, Neil Patel, who I have a very long work relationship and friendship, and always great to discuss things with you. And now I'm looking forward to this discussion.
Thank you so much, Florian. This was an excellent talk. I think we covered most of what we deal normally when we have especially severe cases.